A very good afternoon to one and all. I am Arpita from the IGCP group. The topic that we are going to present today is the diagnosis and management of low grade and high grade CIN, a dialogue. And yes, we have with us two experts in this field. First, we have Dr. Nirmala Jayashankar ma'am. Ma'am is a gynecologist at Apollo Hospital, Chennai. And we have with us Dr. Ramani Rajendran ma'am. She is a retired professor at the Department of Obstetrics and Gynecology at Madras Medical College. So with this very brief introduction of both of the eminent speakers, I would now request Dr. Nirmala ma'am to please take over the session. Over to you, ma'am.
Hello, everyone. Thank you, Arpita, for this kind invitation. Diagnosis and management of low and high-grade cervical intraepithelial neoplasia is the talk today, and it is going to be a dialogue between two of us. I, Dr. Nirmala Jayashankar.
I, Dr. Ramani Rajendran.
So both of us would kind of bring in a dialogue to bring out the clinical significance as to how we should diagnose and manage high and low grade lesions. When you talk about cervical cancer, this is the only cancer which is completely preventable, yet this is the second most common cancer after the cancer of the breast. And when you look at the global burden of the cervical cancer, the calculated incidence of cervical cancer globally is about 6 lakhs, and India, by its sheer population, contributes to 1/5 of the global cervical cancer burden. So this is something which we as gynecologists should try and reverse, and we should try to bring a cancer-free, cervical cancer-free India.
Thank you, Dr. Nirmala and Dr. Aprita. In spite of cervix being an easily accessible organ, all you need is a SIM spectrum to expose the cervix. And most of the gynecologists of recent times, I think this habit is slowly dying. And all the lesions on the cervix have got a long precancerous period of about 15 to 20 years. And among the cancers, it is 100% preventable and curable, provided it is diagnosed early enough.
Yes, we both want to stress that cervical cancer is the only cancer which is 100% preventable and curable because it's easily accessible clinically to see, and it has got a long precancerous stage. And so it's our duty to save these beautiful young women of our country from cervical cancer by way of primary prevention.
So way back in 1970, Zerold Hard Hussein suggested there is a link, a viral link between cervical cancer and HPV. But then to establish this, it took nearly 25 years. And in 1995, the World Health Organization declared HPV as an carcinogen, which is responsible for 99% of the cancer cervix. And for this research, he was awarded the Nobel Prize in 2008.
So it took him 20 long years to establish. And here we have a vaccine which can actually take care of the HPV infection and cervical cancer. Some facts about HPV infection: it's a ubiquitous infection. Large number of women would acquire HPV infection sometime during the lifetime, but majority of us would clear the infection without developing any disease. But few women, for various reasons, develop precancerous lesions and cervical cancer over a period of time. If it is not detected and cured, then this can lead on to cervical cancer.
So coming to the HPV, there are about 100 species that are identified, which infects the skin and the mucous membrane. and they are classified into two groups according to its oncogenicity. They are the low risk group, mainly the 6 and 11, which causes the genital warts or condyloma. The high risk group, which is about 11 to 12 in that group.
Out of which 16 and 18, we want you to remember the sweet 16 and 18. These are the high risk HPV we want you to remember.
So this is again to emphasize that most of this 16, 18 and 31, 33 and 45 are responsible for majority of the cervical cancers. And this is again an emphasis to say that more than 75% of the cervical cancers and more than 50% of vaginal and vulval cancers are caused by 16 and 18. Coming to India alone, the distribution of the HPV is around 76.7% in invasive cancers.
So 76% of invasive cervical cancers, if only we vaccinate our young girls at the appropriate time, before their sexual debut or before they get married in our country, we will be able to prevent such a large number of cervical cancer. And this is what we want to emphasize in today's dialogue.
So the human papilloma infection enters the mucous membrane or the basal layer through micro abrasions that are caused during sexual intercourse. And once they go to the basal layer, from there, as the cells mature into basal, parabasal, intermediate, superficial cells, once they come to the superficial cells, they are then exfoliated along with the cells. And
so when we look at the HPV infection, we said majority of the HPV infection may clear. But supposing it persists, then it forms low-grade lesion, and it takes about 5 years to transform itself into a high-grade, and from high-grade, for it to become an invasive cervical cancer, it takes a very long time. If during this prodromal stage, if the patient is offered either a pap smear or a visual inspection with acetic acid, or we offer some form of cervical screening, then we will be able to prevent the invasive cervical cancer in these women.
So coming to the secondary prevention, it is only by screening. So once a screen test is positive, we have to treat the detected lesions and adequately follow them up. So coming to the screening methodologies, the time known is the pap smear. It's way back in 1925. George Papnicolo was the first person who has obtained smears from his wife and started examining them. And then he was very highly excited when he saw the cancer cells in patients with cervical, in patients with uterine cancer, cervix cells, cervical cancer.
So when we talk about secondary prevention, we said HPV vaccine would be a primary prevention. The secondary prevention for a very long time, it was in the form of a pap smear. But in a low resource country like ours, even if you do a visual inspection with acetic acid, then it would be good enough to pick up any abnormal looking cervix and then to refer them to a higher centers for colposcopy and treatment. Now, in a country like ours, where we do not have adequate cytopathologists to read the pap smear, then HPV DNA co-testing would definitely go a long way. Dr. Ramani will tell us the details about all this.
Next. So here it is very important for us when you visualize the cervix to identify the new squamocolumnar junction. The junction between the pale pink and the red area is the new squamocolumnar junction. And from here, the distance between 3 and 4 is the transformation zone. So here you have a nabothian follicle. Here you have a crypt opening. Those are the landmarks of the old squamocolumnar junction. So you have to draw an imaginary circle that forms the boundary of the old squamocolumnar junction, and the area between the stratified squamous epithelium and the columnar cells, that is the new squamocolumnar junction. This is the transformation zone.
So in short, majority of all the precancerous and the cervical cancer, they come from the transformation zone. And that's the reason why Dr. Ramani is explaining in great detail as to you have to identify the new squamocolumnar junction, and you need to kind of imagine where the whole squamocolumnar junction would be by the presence of a crypt opening or a Nabothian follicle. And you need to concentrate the transformation zone. And when you take a pap smear, you definitely have to take the cells from this transformation zone.
So when you take a smear, originally we were using only the IS spatula. With the IS spatula, you have to combine it with the endocervical brush. Only then you will get a sample from the ectocervix, endocervix, and the transformation zone. But then later they found that majority of the cells goes along with the discarded devices. So there was a lot of false negative. Then they went into the liquid-based cytology, wherein the brush has got bristles of different size, different length, and this is rotated in such a way as shown in the next slide. As shown in this short video. So you insert the long bristles into the os, external os, and rotate it in a clockwise or anti-clockwise. It's better to maintain the clockwise direction, say about 8 to 10 times, and then the brush is removed and the brush head is vigorously agitated into the liquid medium that is sent along with the brush. Next slide. So when you do, so in the liquid-based cytology, we are able to have a clear, cervical cells are seen as a monolayer, and it is easy for identification of dysplastic cells. And at the same time, the instance of inadequate smears have drastically come down after the liquid-based cytology. Whereas on the other side, on the right side, you see the conventional smear, where we have to dig out for precancerous cells among blood, mucus, and other artifacts.
So in other words, our accuracy of diagnosis depends upon how well we take the pap smear, and we need to give a good smear to the cytopathologist. And when we use a liquid-based cytology, we get this thin preparation, which the pathologists are able to identify and tell us clearly, so that the false positive and the false negative of the pap smear, it's negated.
So coming to the correlation between the precursors lesions of the cervical cancer, previously it was mild dysplasia. That terminology has been given away. Now we have the low-grade squamous intraepithelial lesions, which consist on cytology of CIN1, where the abnormal cells are restricted to the lower one-third. Whereas the high-grade squamous intraepithelial lesions comprises of both CIN2 and CIN3. That is, in CIN2, there is the abnormal cell infiltration up to the middle 2/3. Whereas in CIN3, it is from the basement membrane almost nearing the surface, but still few cells remain intact. Whereas in situ, the entire length, right from the surface to the basement membrane, are infiltrated with abnormal cells. So CIN2, CIN3 are now comes under the high-grade squamous intraepithelial lesions.
So previous terminology is now made very simple. Either you you get a low grade or a high grade. So high grade squamous intraepithelial neoplasia, it will encompass CIN2 and CIN3.
So the remaining fluid in the liquid-based cytology, after taking away the cervical cells, is collected in the same container and is transported to the virology lab for the HPV detection. So originally the HPV detection was done by hybrid capture tube, which will only tell us whether this high-grade, high-risk HPV are detected, DNA is detected or not detected. And then they have developed other real-time PCR tests, in which we will be able to know if 16 and 18 are possible. And in the Gene Expert and other tests, they classify them as 16, 18, 45, and other 11 into the other group and say if they are detected. Currently, the WHO in July 2021 has recommended the HPV detection as the primary method of screening for the entire world. That has been the recommendation. But this currently this facility is not available everywhere. Till the time we catch up with this, we have to continue with the visual methods of detection. In the direct visual inspection of cervix, you will be able to, today you are able, in the OP you see a case where the vagina is filled with a growth. Then this patient has come to you about 2 to 3 years earlier. Then you would have detected the tumor, but it would have been by say 2 or 3 centimeters. So you would have been able to detect, reduce only the mortality and morbidity. Only when you detect pre-malignant lesions, you will be able to reduce the incidence of cancer. That is done by visual inspection of cervix with acetic acid under magnification. For this, we use 5% acetic acid, and the normal squamous epithelium appears pale pink. The columnar cells appears red due to the reflection of light from the underlying stroma. It is a very simple procedure. Like any other gynec procedure, patient in lithotomy, cervix is cleaned with a moist saline swab, and then it's sprayed with 5% acetic acid, and the interpretation is given after 1 to 2 minutes. So here what happens, you have the superficial layers, the intermediate, parabasal, basal, the stroma with a rich network of blood vessels. In actual life, this is a diagrammatic representation. In actual life, it is about 30 to 35 layers thick. So the light passes through 35 layers, again gets reflected through 35 layers. So it appears as pale pink. Whereas the columnar cells are single layer cells with a rich network of blood vessels, all the light gets absorbed and gets reflected. It appears bright red. It's like holding a torch underneath your hand and watching the colors. When you add acetic acid, 2 things happen. It coagulates the mucus, so you have a better view. And apart from that, the acetic acid causes dehydration of the cells and coagulation of the cellular proteins, which are very well shows out the dysplastic cells. See, just like heating the egg albumin, on heating the albumin gets precipitated and becomes like a thick white opaque layer. Likewise, when you have an area of abnormal cells, when you add acetic acid, all the nucleoproteins gets coagulated and precipitated. It forms a thick, white, opaque layer, doesn't allow any light to penetrate, and the entire light gets reflected as an aceto-white patch. Coming to the visual inspection of cervix with Lugol's iron, as long as the patient is during the reproductive age group, from menarche to menopause, superficial layers will produce glycogen. This glycogen will combine with the iodine and form nice dark mahogany brown or blackish brown. Whereas the columnar cells do not produce glycogen, so they don't take up iodine, they remain as it is. Whenever you have a patch in the areas of CIN and invasive cancer, do not take up iodine. They are abnormal cells, they don't produce glycogen. They appear as thick mustard yellow or saffron yellow areas. So this is again a picture of VIA. When we add acetic acid, the there is no aceto white patch. Iodine nice dark mahogany brown color. So a healthy cervix has got only two colors, brown, pale pink and red, brown and pink. So when you add acetic acid, you see a white patch, right? Pale pink, stratified squamous epithelium, the red columnar cells, and an aceto-white epithelium. Three colors, brown, pink, and mustard. Whenever you see three colors on the cervix, it's an abnormal cervix. It's a VIA, VILA positive. Again, this is another example to show you of VIA and VILA positive. So when you have, so you can have VIA positive suggestive of invasive cancer. When you add acetic acid, this is a typical exophytic cauliflower-like growth that bleeds on touch, and typical mustard yellow. So whenever you see such a case with visual inspection of cervix, you immediately take a biopsy and send it to a tertiary center which has a cancer unit.
So thank you, Ramani, for so beautifully illustrating the various visual inspection and telling us if you see more than two colors, it should be suspicious, and when necessary, take a biopsy and then send. So whenever you do a screening test and the screening test become positive, then you need to refer the patient for a colposcopy. The symptoms the patient could have would be in the form of postcoital, intermenstrual, postmenopausal bleeding, or a persistent vaginal discharge. Or when you do a visual inspection, it can be positive. A PAP can report as ascus or ascus-H, or it could be low-grade squamous intraepithelial lesion or high-grade. Whenever there is a positive for HPV or a suspicious looking cervix, these are the indications for referral to colposcopy.
So colposcopy is nothing but a binocular stereoscopic microscope that's mounted on a stand for a good magnification of the cervix with a different light source to see the to visualize the cervix. So we follow this International Federation of Cervical Pathology and Colposcopy for its interpretation. And once we put the patient in dorsal lithotomy and clean the cervix with a moist saline swab, we switch on the green filter to see the abnormal blood vessel pattern. On the right side, we have the abnormal blood vessel pattern, which are of bizarre shape and size. And on the left side, we have the irregular branching, tree-like branching variety. This is normal. You can also at times see such atypical blood vessels which are pathognomonic of invasive or in situ cancers. This is the waist thread appearance, which is like the waste that you get in the mechanic shed to wiping the grease. Coming to the abnormal colposcopic findings, first thing we have to give a description of the location of the lesions and the size of the lesions. They are graded into two types, namely the grade 1 or the minor lesions, which have four important features, namely thin aceto-white epithelium with irregular geographical borders, with fine mosaic pattern and fine punctations. So this is the faint thin aceto-white patch. See, it is within the transformation zone. That is the old squamocolumnar junction. This is the new squamocolumnar junction. This is again another picture which showing a flat, thin aceto-white patch with irregular borders. On iodine, it has got typically iodine negativity. Can you appreciate the fine mosaic pattern? Actually, mosaic pattern is the blood vessel pattern observed in colposcopy is gives you an idea of the new capillary budding that takes place in this pathological epithelium, which has got a high metabolic activity. So as it grows, it compresses the blood vessels and pushes them apart. So the intercapillary distance is the mosaic pattern. That tells you how severe is the lesion. Can you appreciate the fine mosaic pattern here? Coming to the punctations, this refers to the dilated capillaries terminating on the surface. Head-on view of capillaries that are terminating on the surface. When you have fine punctations, the punctations, it's an indirect evidence of the caliber of the blood vessels. So these are fine punctations, like taking a white paper and pricking it with pin. This is how it looks. Coming to the major or grade 2, you have about 7 changes. First is a rapid appearance of acetowhiteness. You spray acetic acid. By the time you turn to take a swab, it becomes dense acetowhite with sharp raised borders. Can you appreciate the coarse mosaic pattern? See, the intercapillary distance here is very much increased. And the caliber of the blood vessels are represented by coarse punctations. And normally these are the crypt openings which are minute. When there is abnormal cells infiltrating the cervix, they infiltrate the entire circumference of this crypt openings, and they appear as cuffed crypt openings or rimmed glands. So inner border sign, here you have a large lesion, circumferential lesion. Within that lesion, you are able to see a more dense white area. And this is a very important sign, and it is usually indicative of a high-grade lesion. So this is again another example where you have the cervix is replaced by a groove, but here there is a more dense acetowhite area. Likewise, here again on the right side, the lesions are more dense. Coming to the ridge sign. Ridge sign is actually there's something, a protuberance on the cervix. When you add acetic acid with a flat cervix, but here they all come out like a ridge and protrude outside, right? As if something is stuck to the cervix. These two signs, inner border sign and the ridge sign, are pathognomonic of high-grade lesions. Coming to the non-specific signs, the most important is the leukoplakia. Leukoplakia is nothing but keratosis or pigmentation or hyperkeratosis or keratosis, wherein when you put in a speculum without the application of acetic acid, you see a white layer. I describe this as an icing on the cervix. And when you add iodine, it is completely iodine negative. The problem here is it is essentially benign, but it can cap a malignant area. So the abnormal blood vessel patterns are all masked. So whenever you see a leukoplakia of the cervix or of the polyps, one has to biopsy. When we biopsied this patient, it came out as infiltrating large cell keratinizing squamous cell carcinoma. So it is a lesson that has to be taken. Whenever you see a white patch on the cervix, a leukoplakia, it is mandatory that we do a biopsy.
Thank you, Ramani, for showing us very beautifully with illustrations and telling us how the acetowhite has to be looked at, whether it is very thin, dense acetowhite, and also telling about the ridge sign or the inner border sign, which can be pathognomonic of a high-grade lesion, and also emphasizing the importance that when you have a leukoplakia, the leukoplakia can hide a high-grade lesion, and hence you definitely need to biopsy. So when we talk about the secondary prevention, the secondary prevention consists of a pap smear, and if a pap smear is abnormal, it consists of a colposcopy. Now let's look at some case-based discussion so that we will tell you how to manage a low-grade lesion and how to manage a high-grade lesion. Ramni, your first patient is a 27-year-old software engineer, married for 2 years, and has had a normal delivery about a year ago. She notices a vaginal discharge, which is non-itchy, foul-smelling, not blood-stained, and she undergoes a pap smear, and it says negative for intraepithelial lesions, but with a shift in the flora towards bacterial vaginosis. So she gets treated for a bacterial vaginosis, but then she comes back after 6 months to you with the same complaint. And hence, a colposcopy has been performed. Can you take us through the colposcopy findings?
So this is a speculum examination of the cervix. So you are able to make out the new squamocolumnar junction completely. That is, I normally tell the students that when you put in the speculum, the cervix should look at you, right? So this is the new squamocolumnar junction. Here is a crypt or a small Levothian follicle. That is the old squamocolumnar junction. And on green filter, there are no abnormal blood vessels noted. The new so on acetic acid, a faint aceto-white patch. Faint aceto-white patch away from the new squamocolumnar junction is seen between, say, 11 and 12 o'clock position. On adding Lugol's iodine, it is very well demarcated, totally iodine negative. So we normally do a small scoring system so that everybody would it will be
the same language.
So we take into 5 characteristics here: aceto-white uptake, margins, vessels, lesion size, and iodine staining. Each one is given a score of 0, 1, and 2. The total score is 10. So here, when we have done the sweet score, it's only 4. So any score less than 5 is usually a low-grade lesion which would regress. So this we can label it as subclinical papilloma infection, and before the age of 30, no need for a HPV DNA testing, and she needs observation and follow-up. How will you follow up? After 1 year, when we follow her up after observation, we can find 4 things. Totally the lesion would have disappeared. We call this as clearance. Or the lesions are still there but regressed in size. Or they are at the same size, we call it. This is persistence. Or all the lesions have joined together and formed a new ones. And this is known as progression. Those who have persistent and progressive lesions have to be monitored more closely.
So when you mean monitored more closely, can you elaborate on that? What do you normally do? You said it can clear, it can regress, but when it is persisting, will you do a HPV co-testing?
Yes, by 30, once she crosses 30, we have to do HPV DNA testing. That will give us an idea about the genotype with which she is infected, and then a colposcopy will tell us whether there is any lesion, and then we'll have to treat her accordingly.
So we saw a low-grade lesion. Our second patient is 37 years, married for 6 years, presenting with profuse, itchy discharge. The family physician has done a pap smear, which confirmed normal findings on speculum examination. She was referred for colposcopy because of the presence of coilocytosis. The impression was inflammatory smear, negative for intraepithelial lesions or malignancy, presence of coilocytosis suggesting a HPV DNA. A HPV DNA testing showed HPV 31 high risk being positive, and hence the patient was referred for a colposcopy.
In colposcopy, we were able to the cervix is adequate for visualization. New SAG seen completely. It's a type 1 TZ, no abnormal blood vessel pattern noted. And on acetic acid application, you are able to make out a dense aceto-white patch between, say, between 10 and 2 o'clock. It's a shady milky white with irregular margins and completely iodine negative. So in this patient, we will come to the treatment in the end of the low-grade cases. Coming to the next case, she is a 42-year-old lady who who had a pap smear in the master health checker, and it was reported as ascus. So whenever you have an ascus, it means the cells are not normal, but they are not like a low-grade lesion as well. So that needs a triage with a high-risk HPV DNA. So a high-risk HPV DNA was done. It was negative for all 16, 18, 45 and other HPV high-risk groups. So when we did the colposcopy, so speculum examination, cervix was congested. On green filter, you are able to make out strawberry red spots. On adding acetic acid, they all turn, they get, they bleed on touch and they get whitish in nature. And when you add iodine, this gives you the typical leopard skin spots. Likewise, this is another case where
So that's pathognomonic of
trichomonas vaginalis.
yes. So
Which
it's
is
to be treated
with drugs, right? So the typical leopard skin spots. Likewise, in this case, we are able to make out fine mottling throughout. This is pathognomonic of candidiasis, and many diabetics are diagnosed in the colposcopy clinics. So it is mandatory whenever you have an ascus with HPV negative to screen them for both HIV and have the blood sugar estimated.
So the fourth patient is a 35-year-old para 2 live 2 on her routine health checkup. The liquid-based cytology showed a low-grade squamous intraepithelial lesion with reactive cellular inflammatory changes, and hence this lady was referred for a colposcopy. So on colposcopy,
They were cervix adequate for visualization, new SCG seen completely. I think the green filter picture is not there. There was no abnormal blood vessels, but a faint patch that was developing between 11 to 2 o'clock with a fine mosaic pattern and totally iodine negative. So coming to this case 5, she's a 40-year-old lady, referred for white discharge for 3 months. LBC with co-testing was done. LBC was reported as low-grade squamous intraepithelial lesions. And her HPV DNA was negative for 16, 18, 45, but positive for other high-risk groups. So cervix appeared congested, new SCG seen completely. This is the white discharge. It is not leukoplakia. No abnormal blood vessel pattern. Faint acetylwhite patch at 12 o'clock. Resembling with irregular margins. Fine mosaic pattern, very well appreciated with punctations. So we'll come to the management now.
so we saw various colposcopic appearances of a low-grade lesion. We have not still touched upon the high-grade lesion. So now we have kind of covered how you will diagnose a low-grade on colposcopy comfortably. And coming to the treatment modalities, we have got both ablative treatment and excisional treatment. Ablative treatment would be either in the form of a cold coagulation or a cryocautery. And Dr. Ramani will take us through the treatment modalities of this low-grade lesion and also the follow-up.
So the 2 important principles that you have to remember is, the rule number 1 is treat or excise the entire transformation zone. So here, this is the new squamocolumnar junction. I think here there is an ablative cyst. So that is the old squamocolumnar junction. So this entire transformation zone has to be treated. Rule number 2 is you will have to treat for an adequate depth. In this picture, we have seen the crepes extend up to 6 mm. So you need to have a good depth coverage so that you will be able to eradicate the disease in the endocervical canal and the crypts. So coming to the ablative treatment, it has got some eligibility criteria. First is the transformation zone should be a type 1. The entire lesion should be on the ectocervix. No, it should not extend into the endocervical canal or the vagina. There should be no evidence or suspicion of invasive cancer, no suspicion of any glandular abnormality, ideally no discrepancy between cytology, colposcopy and histopathology. And 3 P's are patient should not be in periods, should not be pregnant, and should be no evidence of PID. So this is the cryocautery gun, and we follow the double freeze method. We do a slow thaw, then a freeze for 3 minutes, thaw for 5 minutes, freeze for 3 minutes, again thaw for 5 minutes. So a rapid freeze followed by a slow thaw is more damaging to the neoplastic cells. So it produces more destruction than a single cycle. And the double freeze method is supposed to reduce the instance of residual disease rather than a single freeze. This is how it looks at the end of the double freeze method. So here again, the main disadvantage with the cryocautery is you have a lesion here, and I think it's proved to be CIN1, totally on the ectocervix. The lesion should be of such a size that it is smaller than that of the probe, so that the ice ball formation would be 2 to 3 millimeters beyond that. This is an important factor. If there are a number of lesions or an irregularly shaped cervix, then it is not possible to do the ablative therapy with cryocautery.
But the advantage of a cryo is it can be easily transported, and it is simple, does not require anesthesia. And I think for a low-grade lesion is sufficiently, it is good enough. But you need to choose so that there are no lesions which are not covered by your cryoprobe. You need to choose the appropriate cryoprobe and then do it properly. Then I think it's a very good method.
So this is again a sample of cervix with a new squamous columnar junction is visualized completely. Type 1 TZ. There's a lesion on the anterior lip, posterior lip, and a small satellite lesion on the 3 o'clock portion. Fine mosaic pattern, fully visible lesions. Sorry. The lesions are mapped, cryocautery is done, and this is how it looks at the end of the procedure. So this cryocautery has stood the test of time. It's there in use for more than 60, 70 years. And you have to get a consent. You will have to consider for profuse watery discharge for 6 weeks and for the need for abstinence for the same time. So this is a short video about how the procedure is being done. So once the trigger is on, the gas flows and the probe is stuck to the cervix, and you see the ice ball formation well beyond the margins of the lesion. Then you have to wait patiently. This is almost about 16 to 20 minutes procedure. If you get impatient and you pull, it will cause an avulsion of the cervix. You'll have to wait. Once the trigger is off, the ice would melt, and then you will have to, the frost would melt, and then you'll have to slide the probe out. So that this is in short. Here we use in cryo, we use carbon dioxide and nitrous oxide for freezing, which is around -68 is carbon dioxide, and nitrous oxide is around -89. The other option for low-grade treatment is using heat, that is thermal. That's where we heat the probe to 100 degrees centigrade. This was previously known as cold coagulation. That is, in olden days, there was diathermy to the cervix done for cervical erosion, where they used a current up to 300 degrees. Right? And so that was so compared to 300 degrees, this is only 100 degrees, so it was comparatively cold. So they called it as cold coagulation. This led to a lot of confusion. So that has been, the name has been given off, and now that is being renamed as thermal ablator. Here, in cryo, the probe is -20, so that the cell water freezes, it becomes ice, it expands, it ruptures, and it causes cryonecrosis. Here, when you touch the cervix, the point of contact, the cell water boils, gets converted into vapor, it expands, the cell ruptures, and it causes a destruction of the tissue. The depth of destruction is around 6 to 7 mm. Here it is a handheld device, very simple, very light, and it is easy to sterilize, and it doesn't require any refrigerant gases like carbon dioxide and nitrous oxide. And the battery can be used for about 30 cases once charged. And the main advantage is the multiple applications can be done. So even if you have an irregular cervix or a hypertrophied cervix with multiple lesions, this can be very, very useful. So this is again a 40-year-old lady with a lesion on anterior posterior lip. So we have combined it with a biopsy. First thing is we do a biopsy. It starts bleeding, so we have plugged the vagina. Once the bleeding has reduced, we then take the probe, the thermal ablator, and there is a button on the console. Once you give a long press, you see 4 lights gets on, and once the 4 lights are steady, then the probe is ready for use. So you touch the surface and do this. Now the probe is heated, and each light will get switched off around after 5 to 6 seconds. Very difficult to take pictures because everything comes in the same straight line. So this is how the cervix looks at the end of the procedure. So you have taken a specimen, so you can have a histopathology report and correlate with your colposcopic findings.
So we saw both cryo and the handheld thermal coagulation can be used in the field as well, so that the patient who needs it, they become eligible for that.
So this is a 38-year-old staff nurse who was in NCD department. So she she was having discharge, so she first did her HPV testing. And 16 was positive, 18 was not detected. She's married for 13 years and with 2 kids. And so she had a pap smear, but that was normal. But again, next year she did, the biopsy was positive. She had a biopsy that turned out to be chronic cervicitis. 2021 COVID crisis. 22 she again had her HPV DNA done. It was again positive for 16. And the LBC report was reported as low-grade lesion. On examination, cervix was hypertrophy with first-degree descent. First-degree descent, the old bilateral tear. On the posterior lip, there was a thick cyto-white band, totally ID negative. Biopsy was done, it was CIN2. It was CIN2. And she had thermal ablation. See, after the ablation, this is 6 months after the ablation. The cervix had beautifully healed. The new squamous columnar junction is still visible. And she is doing well. So when you have multiple lesions, you can do overlapping applications with the thermal ablator. That is the main advantage. It can be done up to 4 applications. And this is the next case. This is a 45-year-old lady with white discharge, and her pap smear was reported as ascus H. The cervix for on speculum examination looks normal. There was no abnormal blood vessel, so score is only 1 for the blood vessel pattern. And for the aceto white patch and the margins, it is each 1. And it was almost on all the quadrants with total iodine negativity. So the total score was 7. Multiple biopsies was done, and that turned out to be CIN 2 to 3. So LLETZ was done for her, and the resected margins were negative. She's on annual follow-up. Her both LBC and HPV DNA tests are negative.
So could you show us a video of the LLETZ so that we will complete?
After the next case. So this is a 38-year-old lady referred for cervical screening. Actually, she brought her daughter for a checkup to another practitioner. And on the way, just like that, she said, I'm having a mild discharge. So that doctor has done a PV and sent her to me for opinion. So this was how the cervix was looking on speculum examination. There were abnormal blood vessels. Acetic acid had confirmed the diagnosis. The LLETZ sign positive, dense aceto whiteness, rapid appearance, coarse palpations and mosaic pattern, inner border sign positive, and the LLETZ sign positive. You can see the cuffed glands all over, and total iodine negativity. The score was 10. So we did a colposcopic directed biopsy, and that turned out to be CIN3. To me, this doesn't correlated with the colposcopic findings. So we decided to do because we had taken biopsy from this area alone. This is almost projecting out. So we have taken, it does not reach the basement membrane. So we repeated a biopsy. The main disadvantage of the colposcopic directed biopsy is that we might miss a micro invasion. So we did a micro invasion, we did a LLETZ in her, and that turned out to be micro invasive CA, and she has had a hysterectomy with no dissection. So coming to the management options in such cases, it's LLETZ or LLETZ, both are the same. And here we use loops of different size depending upon the type of the transformation zone. Because we have to decide on the loop size so that we give a complete clearance of the disease in the crypts. Most important is we have to have a smoke vent in the speculum and the usual electrocautery machines. Here we give a pericervical block. Right? Either this is wrong, 2, 4, 8, and 10. And then we place the loop in the cautery pin and move it from 3 to 9 to 3 o'clock position. So the crater is then sealed off with ball cautery and Monson space. This is how it looks after 6 months. So first thing is so we have to map the lesion with acetic acid iodine. Then we give a pericervical block. Once the block is on, the cryocautery, the loop is attached to the cautery pen. With the yellow button on, we slowly cover the lesion and come out at 3 o'clock position. Use the ball cautery to seal all the vessels. This is how it looks at the end of the procedure. So because of the ease, next slide. Okay. Because of the ease and efficacy, it has got a worldwide penetration. And most important is you have to remove the cervix as a lesion in a single piece. Only then it's possible to give the interpretation.
And the same can be done with a cold knife conization also. We only have like 7 minutes left for our presentation. So
this is the last case where Mr. G, 40 years old, 2 previous cesarean, routine master health checkup pap smear turned out to be LLETZ. ectocervix biopsy, CIN3. Lap hysterectomy was done. 2 years later, she developed some discharge, so repeated pap smear, and that came out as ascus, and she was referred for colposcopy. The first colposcopy visit, I suggested a biopsy. She said her daughter is doing +2 and she came back after 2 to 3 months. Again, insisted on with a wall biopsy. She said, why are you thinking of cancer? In case if that is so, I will go and meet the oncosurgeon and the radio-oncologist. And nothing was confirmatory. She came back for the third time. First time, this is how it looked. I was not very happy about the peeling of the epithelium, which is called as erosion. And the second time when she came, I saw one piece of the epithelium peeled off and hanging like a rag. That is a very typical of rat sign, which is clearly iodine negative. And third, it was almost confirmatory that it is a malignancy. But all these on PV will not feel like a hard tumor. They will be like a soft sponge. That's how it was not appreciated by the surgical oncologist. And the biopsy came out as moderately differentiated squamous cell carcinoma, and she had complete therapy. Coming to the follow-up, follow-up has to be done for next 20 years. Right? Whenever you operate on a patient with CIN3, the method is to follow them is via HPV testing, because a positive HPV testing, even in the presence of normal cytology, can detect treatment failure more quickly and more accurately. Cervical cancer screening is very low in India, as low as 3% between 25 to 70 years of age. Only when you combine primary prevention in the form of HPV vaccination and regular screening, you will be able to reduce cancer risk by 63%. So a cervix cannot be judged by its look. See, this is a normal looking cervix congested. When you add acetic acid, you are able to see a large circumferential lesion. The cervix needs to be certified to say it is normal. So on November 17th marks the Cancer Cervix Elimination Day. They brought in the strategy 90-70-90, by which you can reduce the incidence of cancer to about 4 per lakh. So meaning 90% of the girls have to be vaccinated by 15 years of age. 70% of the women should be screened with a highly effective screening method at least twice in their lifetime, 35 and 45. 90% of women detected with precancers have to be treated, and 90% of women with invasive cancer have to be managed in the concerned district cancer units. So in short, to remember this, 90-70-90, one has to remember GST. Right? So now being Deepavali season, you will be every bill that you see, you will see a GST. Thank you.
So we would like to thank the organization for giving us an opportunity, and I would like to sincerely thank Dr. Ramani, who is the nodal officer for training all the medical officers in Tamil Nadu under her care, and she is a certified colposcopist. And with all her passion for presenting various numbers, various pictures of the colposcopy, and taking us through what to do in a low grade and what to do in a high grade, and how primary prevention is so important, and then how do we follow it up. So I hope we have tried to clear it with a couple of cases and the pictures, and we would like to thank everyone for logging in, and also the organization for the opportunity.
Thank you very much for giving us this opportunity, and all the participants for their valuable time and hearing. Thank you.
Thank you, Dr. Nirmala ma'am, and thank you, Dr. Ramani ma'am. Thank you so much for your time and putting up so much effort in this session. It was beautiful, and the way you have you have explained the complex topic into a very simpler form. I would really appreciate that. Thanks to both of you. Thank you so much, doctors.
Thank you, Arpita.
Thank you, Ma.
Thank you. Thank you so much. Thanks to all the audiences. So with that, we are going to close the session for today. Thank you all.
Arpita, are there any questions which Dr. Ramani needs to clarify or answer?
No, ma'am, nothing as such has come.
Thank you, Arpita.
Thank you.
Thank you so much, ma'am.